Hello, I'm Boon Singh. Today I'm going to talk about the approach to the abdominal pain and dyspepsia, and this mini lecture is specifically catered for undergraduate medical students doing their internal medicine rotations. Here we have three learning outcomes. Number one is to describe a logical and practical approach to assessing the patients with abdominal pain and dyspepsia, list the differential diagnosis, and describe the overview of the management of specifically peptic ulcer disease and reflux esophagitis. Before you proceed with the lecture, it would be nice for you to pause the video to recall the prior knowledge on the physiological concept of somatic, visceral, and reflex pain, neurohormonal regulations of gastric acid secretions, the electrophysiology of swallowing, and gastric emptyings. In this lecture, we will dwell deeper into two symptoms. Number one is dyspepsia. There's no unified definitions on what is a dyspepsia, but essentially it is a symptom of upper gastrointestinal disease. It can mean upper abdominal pain or discomfort, heartburn, gastric reflux, fullness, bloating, early satiety, nausea, and vomiting. The most common cause of dyspepsia is a functional dyspepsia, means there's no underlying organic cause. Our main task in taking history of dyspepsia is to identify organic diseases. It can be iatrogenicity, such as NSAIDs-induced peptic ulcer disease, or the use of steroids, especially in adulterated traditional medications, the use of nitrates and calcium channel blocker. Number two cause could be a Helicobacter pylori. Mostly it is asymptomatic, but we can get history on the sanitations and the family history of patients with a Helicobacter pylori eradications. For peptic ulcer disease, it is also most commonly asymptomatic, but we can ask for a postprandial epigastric pain or hematemesis. For gastric cancer, it is most common among East Asians, and you should ask for constitutional symptoms, dysphagia, or passing melanic stools. Patients with dyspepsia can have biliary or gallstone disease, and for this you will need to ask about biliary colic. It is an abdominal pain that takes for around 30 minutes and plateau up to 6 hours. And if there's ascending cholangitis, patients may get fever or jaundice. Patients with dyspepsia can have a pancreatic disease, and they may present with asthenia, weight loss, anorexia, and epigastric pain. The second symptom is more broad. It is abdominal pain. As with any pain history taking, you should note the site of the pain, the onset, the characteristic radiations, associated symptoms, the timing, exacerbating and relieving factors, and the severity of pain. This lecture will focus specifically on epigastric pain, and for patients with epigastric pain, there are a few differential diagnoses that we need to consider. That is a gastrointestinal disease, hepatobiliary diseases, pancreatitis, or cardiac disease. We will now examine the patients with abdominal pain and dyspepsia. Our first task is to exclude an acute abdomen. You will need to identify patients who are systematically unwell, shows the sign of peritonism and ileus. After having satisfied that the patient is not having acute abdomen, you can look for pallor, jaundice, and look for nutritional status, specifically malabsorptions in the cachexic patients, hepatomegaly, Courvoisier sign, which is a non-tender but palpable distended gallbladder at the right costal margin. Look for ascites and look for palpable lymph nodes. The main aim of performing investigations for patients with abdominal pain and dyspepsia is to identify the underlying organic cause. The first and foremost test that we should do is a Helicobacter pylori testing. It can be done with or without endoscopy. For patients who do not need endoscopy, we can perform a urea breath test, stool antigen testing, and serology is not typically helpful as it cannot differentiate between a current or past infections. For patients with endoscopy, we can perform a biopsy urease test. Next, we can do a full blood count and iron study, and this is really to look for iron deficiency anemia from chronic GI bleeding. We can do a liver function test to look for features of obstructive jaundice. And if a patient is having a pancreatitis, the inflammatory marker will be raised, as well as the serum lipase, triglyceride, and the patient will have low calcium. We can perform a chest radiograph and an abdominal radiograph. It is really to look for the air under the diaphragms and also features of bowel obstructions. For the decisions to offer endoscopy or CT abdomen should come from a senior clinicians. If you want to know more, you can refer to the NICE Guideline 12, published in 2015. Interestingly, a trial or treatment can be a form of investigations, and we shall give a full dose of PPI for 4 weeks. PPI means proton pump inhibitors, such as omeprazole or pantoprazole. I'll be sharing 2 cases to demonstrate the approach to patients with abdominal pain and dyspepsia. Case number 1 will be on the peptic ulcer disease, published by Dr. Tan in the 1980s in a case from Hospital Kuala Lumpur. Dr. Tan described a 103-year-old female presented with epigastric pain, which shifted to right iliac fossa for a 2 days duration. Patient has loss of weight and loss of appetite for a few months. There's no melanoma. On examinations, the patient was emaciated, pale, non-toxic, and afebrile. She has abdominal tenderness and rigidity in the right iliac fossa. There's no rebound tenderness. Bowel sound was sluggish. The lab shows she has anemia, leukocytosis, which is a neutrophil predominant. The test X-ray showed no air under diaphragm. Initially, the patient was managed conservatively. However, later, she has increasing tenderness and rigidity of the right iliac fossa. Thus, she was referred to a surgeon and an emergency laparotomy was performed, and there's a 2 cm ulcer with a surrounding indurations in the pyloric region anteriorly. The peritoneal cavity also filled with inflammatory exudates. The HPE of the surgical sample shows signs of inflammations and fibrosis. There's no evidence of malignancy. For the specific management outline for patients with a peptic ulcer disease is acid suppressant with antihistamine or a proton pump inhibitor. If a patient has an upper gastrointestinal bleed, then we should perform an endoscopy. If there's a perforation, the patient should manage surgically. And if there's symptomatic anemia or severe anemia, we would perform a blood transfusion. The case 2 is on reflux esophagitis by Yamasaki et al. And this is a more complicated and more complex case, but let us go through the case step by step. The author describes a 62-year-old female presented with dysphagia. She has a complex past medical history where she developed a duodenal perforations after a gynecological surgery, which requiring 4 months of nasogastric tube feeding afterwards. A follow-up video fluoroscopic examinations show a reflux of contrast medium from the stomach to esophagus, indicative of a reflux disease. When she had an esophageal gastroduodenoscopy done, there's a circumferential reflux esophagitis of a grade D and the strictures located at 25 to 40 cm from the incisor teeth. Later, the follow-up noted that the stricture was worsened and the treating team do a balloon dilatations. Currently, on examinations, she was thin with a BMI of 17.8. There's no significant physical findings. Laboratory result shows a mild anemia and liver dysfunctions. The image on the right-hand side of the slide shows an upper gastrointestinal series. Of course, this is a non-moving picture, but essentially it's trying to show a severe stricture measuring 85 mm along the longitudinal axis from the middle to lower thoracic esophagus. The patients also had a CT scan and shows marked wall thickening from the middle to lower thoracic esophagus. The patient was managed surgically by having an esophageectomy. The pictures on the right lower bottom of the slide shows the pathological sample of the esophagus that was resected. From the picture, you can see that there's a severe strictures and scarring of the lower portions of the esophagus. Generally, patients with reflux esophagitis does not require surgery, and surgery is only reserved for a complicated case. Commonly, the patients will have managed by having alginates, commonly the Gaviscon, that can be obtained from over the counter. Patients can be managed with acid suppressant, again, antihistamine or proton pump inhibitor. And if the patient's having a refractory disease, we may want to refer to a gastroenterologist to have esophageal impedance pH or manometry. We have come to the end to the mini lecture on the approach to abdominal pain and dyspepsia. We have covered the presenting symptoms, examination findings, key investigations, and the principle of management specifically on peptic ulcer disease and reflux esophagitis. If you have questions and answers, please leave your comments. Thank you, and see you again in the next lecture.